Welcome to The Explainer. Today, we're diving straight into the high-stakes, clock-ticking reality of snakebite management. We're going to use official clinical protocols to replace panic with absolute, life-saving precision. Because whether you're an avid hiker or a medical professional, the timeline from a snake strike to full recovery is literally measured in minutes and very precise decisions.
Here is our bite-to-bedside journey for today. We'll start with critical first aid protocols, figure out how to distinguish venomous from non-venomous bites, look at the 20-minute clotting test, break down anti-snake venom administration, and finally, wrap up with managing hypersensitivity. Let's get right into it.
Section 1. Critical First Aid Protocol. So we begin in those crucial first minutes immediately after a strike. This is the field response phase. And what you do right here completely dictates the patient's chances before they ever even see a doctor.
The medical protocol outlines this with a really easy-to-remember acronym, the CRIB protocol. It's your exact step-by-step field guide. First, C, comfort and reassure the patient. You have to keep their heart rate down. R, remove tight items. Take off rings, bangles, watches immediately, because trust me, the swelling's going to happen. I, immobilize the limb with a splint, kind of like you would for a fractured bone. Just don't tie it too tight. The first B, keep the bitten area low, at or below the level of the heart. And the final B, bust bad practices.
Now, about busting those bad practices, it is absolutely crucial to know what you must avoid. Pop culture gets this so wrong. Do not apply a tourniquet. Seriously, no way. Why? Because if you take a tourniquet off later, it releases this sudden, fatal rush of concentrated venom straight into the bloodstream. Also, you absolutely shouldn't wash the wound with force, definitely don't apply ice, and never delay treatment by going to faith healers. In this situation, time is tissue, and time is life.
Section 2. Venomous versus non-venomous bites. Okay, let's move to the hospital phase. How do doctors immediately tell a harmless dry bite from a lethal envenomation?
Well, there's a pretty stark clinical contrast. Non-venomous bites, like from a rat snake or a python, mostly just leave a mild puncture wound with minimal pain and no real swelling. Systemically, the patient might have a fast heart rate, but honestly, that's usually just pure anxiety. Venomous bites, though, totally different story. Vipers cause intense pain, heavy bleeding, and blistering. Cobras cause really prominent swelling. But here is the truly terrifying part. Bites from the common crate are often completely painless with zero local swelling. You might not even realize you're in mortal danger.
Because local symptoms can trick you, doctors really rely on systemic signs. Venom basically falls into two categories. Cobras and krites deliver neurotoxins. These attack the nervous system, causing ptosis, which is drooping eyelids, slurred speech, trouble swallowing, and eventually your lungs just stop working. Vipers, on the flip side, use hemotoxins. These literally destroy your blood's ability to clot. So you're looking at bleeding gums, nosebleeds, blood in the urine, and severe internal bleeding.
Section 3. The 20-minute clotting test. To rapidly confirm a hemotoxic viper bite, medical staff use a remarkably cheap but incredibly suspenseful diagnostic tool. No fancy machines required, just a glass tube and some patience.
It's called the 20-minute whole blood clotting test, or 20-WBCT. The procedure is exact. At minute 0, a clinician draws exactly 2 milliliters of fresh venous blood, puts it into a clean, completely dry glass tube, and then they wait. The tube has to sit perfectly still, totally undisturbed for exactly 20 minutes.
And here is the moment of truth. After 20 minutes, you tilt the glass. If the blood just flows like a liquid and hasn't clotted, that is a positive test. The venom has successfully destroyed the body's natural clotting factors. The patient is actively bleeding out internally, and you have to start aggressive therapy immediately.
Section 4. Anti-snake venom administration. All right, once envenomation is clinically confirmed, whether through those systemic signs or a positive clotting test, we enter the treatment phase. And the definitive, life-saving solution here is anti-snake venom, commonly known as ASV.
But hold on. Before giving the cure, doctors have to heed a massive clinical warning. There's a strict directive. Never perform a subcutaneous test dose. Back in the day, doctors would inject a tiny bit of antivenom under the skin just to see if the patient was allergic. Well, we now know that's incredibly dangerous because that tiny test dose can actually trigger a severe, life-threatening allergic reaction all on its own. You have to go straight to the main treatment, just with very high vigilance.
When it's time to treat, the initial protocol is aggressive and urgent.
You start with 10 vials of polyvalent ASV. These get diluted in normal saline or 5% dextrose, and it's infused intravenously over 30 to 60 minutes. And of course, you keep the patient under continuous, very close observation.
Now this brings up a super counterintuitive medical fact that always shocks people. An adult patient gets 10 vials, right? Well, a pediatric patient, a small child, also gets exactly 10 vials. Crazy, right? But think about it. The snake doesn't calculate the size of its victim. It pumps the exact same absolute quantity of venom into a kid as it does into a full-grown adult. So you need the exact same amount of antivenom to neutralize it.
Section 5. Managing ASV hypersensitivity. So, the patient has been bitten, and the ASV is flowing into their veins. But we are definitely not out of the woods yet. The ultimate complication here is that the life-saving cure can sometimes turn right around and attack the patient.
See, ASV is a biological product, often derived from horse antibodies, and the human immune system doesn't always love that. Actually, up to 20% of patients, that's 1 in 5 people, will experience a severe adverse reaction or full-blown anaphylaxis within just minutes of starting the infusion. That's exactly why continuous observation during that first hour is so absolutely critical.
If hypersensitivity strikes, the medical team has to move instantly to prevent cardiac collapse. Step 1. Stop the ASV infusion immediately. Step 2. Hit them with intramuscular adrenaline right into the thigh. Step 3. Push supportive IV medications to calm the immune system. And Step 4. If the patient is still in shock, hit them with a rapid fluid bolus.
Looking at the exact pharmacology of saving that patient, the adrenaline is a 1 to 1,000 concentration, which opens the airways and boosts blood pressure. Next, they push 100 milligrams of IV hydrocortisone, a really powerful steroid, followed by antihistamines like chlorpheniramine and ranitidine. This entire multi-drug cocktail is used to completely stabilize the patient. And here's the amazing part. You don't just abandon the ASI. Once they're stable, the infusion is restarted, just very, very slowly, so you can still neutralize the venom.
From knowing to never apply a tourniquet in the field, to understanding the silent danger of a crate bite, to literally watching blood not clot in a glass tube, surviving a snake bite is all about applied science and calm protocols. So I leave you with this. If the clock started ticking right now for you or someone you love, which step of this protocol will you remember when every single second counts? Thanks for joining me on this explainer. Stay safe, stay informed, and I'll catch you next time.